Hey, I'm David Failing,
And I'm Nick Glass.
and this is our 420 EHR debate. I am taking the affirmative pro electronic health record, and
I'll be doing the against electronic health record.
I have a 2-minute timer that I'll be using for our initial debate stuff. And without further ado, we'll get right into it. In 3, 2, 1, go. All right, so my first point is that an EHR enables the review of a patient's history, their status, and basically the bulk of the information a clinician would need to know on a patient before they even go in and see the patient. So um, a clinician can get a quick review, track trends and vital signs, lab reports, lab results, point of care tests, read a quick H&P, read all the progress notes outside of the room, right before shift change, whatever they need to do before they go see their patient. And they can do that on multiple patients from one screen. So that's my first major point. My second major point is that a clinician can check the side effects of medications, clarify with a physician and a pharmacist, all from one application on the medication administration reconciliation form. So they have access to micromedics and lexicomp, so they can check line compatibility and contraindications. They can contact a pharmacy or physician directly via an instant message. Allergies and interactions are all kept up to date and can be refreshed at any moment, and help with patient care in that regard. And finally, my third major point is that there's reminders built into the EHR that alert clinicians on patient safety issues and if certain things need to be done. Good examples include sepsis and C. diff alerts based on algorithms. So if vitals are trending in a certain way or certain lab reports happen, they can get that alert on the screen and take interventions to deal with that. Timed medications, vaccination reminders are also great examples of alerts that can happen on an EHR that don't really happen on a traditional paper chart. That's 2 minutes right there.
Wonderful. I made some really good points in there.
Thank you,
Oh,
thank you. Man, that's a that 2 minutes goes quick.
that's good.
All
All
right.
right. Hopefully I can fill the 2 minutes.
I'm gonna count you down here.
All right.
3, 2, 1, go.
All right. So I'm going to be doing the negative side of things, or the disagree with the EHR stuff. So I looked at it a little bit from kind of an IT perspective, whereas the current EHR systems are they're heavily exploitable and they're not exactly secure, is in terms of um, like hackers and stuff can like really easily get into it. For example, just in the last year, there's been 12 major cyber attacks on EHR systems. There was a major data breach just up in northern Washington, where hackers stole and held millions of people's medical health records for ransom. So on the whole, they're really not, they need to do more on the security line of things for it to really be, implemented in such a way that it's beneficial for everything. The current, and my second major point is current symptoms are, they're running on very old and underfunded, broken infrastructure that lead to a lot of HIPAA violations, medical errors, and a lot of time there's missing documentation because maybe sometimes people aren't trained correctly. Forbes put out a big report that there's been like 2,000 medical errors between 2012 and 2017, especially in pediatric patients. So EHR can be a good thing, but can also lead to a lot of heavy medical errors, prescription errors and stuff like that. My last big point is that EHR in general is just, it's a very expensive system to implement to begin with. Has a heavy cost burden for both the healthcare system to implement at first, and they have to get the system custom tailored for the needs, and it's it's very, expensive to train the staff as well. I probably went over on 2 minutes.
It's fine. You went over by like 8 seconds, so
Oh,
you're good.
sweet. Okay.
Yeah. No, wow. That's excellent. I did not prepare any of those counterpoints. I did not foresee any of those options as issues. So good on your part. I'm screwed.
Yeah, I mean, I got a little bit of IT stuff, and I kind of look
All
at
right
stuff
on,
from
right
a
on.
security perspective.
So next part of the agenda says we prepare for 2 minutes our counterpoints, but I believe we have shared our Google Doc with each other, so you can see my initial points and I can see your initial points. Do you need time to prepare rebuttals to my initial points, or
Standby.
agreement, disagreement? I don't know. Yeah.
I'm gonna pause for just a sec here.
Yeah.
And we're back. All right, I have a little discussion on how we were gonna go about this part. Okay.
All right. 2-minute rebuttal, Nick.
2-minute rebuttal. So first of all, I thought you had some really good points. And I kind of want to talk about your first major point was, how you said that, enables to like review patient history status and all that. But my biggest rebuttal to that is I feel like it really kind of takes away from, patient care. And, where it's going to eliminate doctors, wanting to go and see their patient face to face. And whereas they'll just look in the chart and then make decisions based on based on the chart rather than actually seeing the patient face to face. And that's where I feel like some of those mistakes can happen, like in some of the stuff that I brought up earlier, where a lot of those misinformation, the misdiagnosis and stuff like that, where, a clinician, is over reliant on the electronic health record, where they're just looking at just a computer screen and they don't actually go and physically, look at their patient. And it can, like I said before, it can cause a lot of medical errors, they give the patient the wrong dose of something or the wrong medication, because they're not seeing the whole picture. They're just seeing a computer screen ahead of them. That's my rebuttal.
Cool. That'll work. I'll take it. All right. So my rebuttal, I'll throw 2 minutes up on my thing here. And three. That's not pause. Oh, cancel. In 3, 2, 1 on my end. All right. So you went from a totally different perspective on why EHRs might not be the best option than I would assume. You went from an IT standpoint. I did not prepare anything for an IT standpoint. So kudos to you for winning that area. I had prepared foreseeable things like you mentioned, like time issues and feasibility issues and interportability issues. I went hard on interportability. So you went on the IT side of things, which is really good. I did not know about those security breaches. That being said, my rebuttal to that is that, yeah, security is always going to be an issue. I've personally have only worked at large medical institutions like university hospitals that have a lot of money and resources to put into security. So we're talking double authentication. We're talking if you want to access the EHR from a home computer or a private device, there's special apps that allow you to get tertiary authentication stuff that allow you to do that. So keeping things more secure. HIPAA compliant devices that lock everything down, devices that only work on the hospital intranet. So you have to be on site to use them, and then die when you leave the hospital, essentially cut all ties. So yeah, security is always going to be an issue, especially for foreign entities that want to mine that kind of data and hold it against us. But yeah, it's definitely an issue that the government needs to look into in terms of providing funding and resources for smaller institutions that have lower IT budgets, smaller IT resources to boost their security for sure. In terms of financial things, I agree that the financial burden to institutions is a huge issue, but I feel like I'll take a little bit more time. I feel like it's also front loaded. in the
Yeah.
initial, go live transition from a non EHR to a new EHR. So I feel like in the end, the way that those institutions are able to bill and mine for financial resources in terms of information from the patient's chart that they can bill to Medicaid, Medicare, other insurance companies, and work with those companies will pay dividends versus the initial lump sum of money that they have to put forward. So there's my 2 cents.
Wonderful. And actually, I do agree that it's very front loaded. And I know in my research on that point, I did find that that is exactly the case, that with the heavy, burden of the cost of everything is really upfront, but it evens out over time because of the efficiency that it increases. Because of the, like you said, like the medical billing aspect, the fact that because EHR is efficient, we can see more patients at a time. We're not doing all this paper charting, and we can see more patients, allows for more billing, and overall can recoup that cost a lot faster.
Yeah. For their final minutes, I think Nick and I have worked on a lot of projects together so far, and a lot of them kind of center around our clinical experience that we've had. Nick worked in the ED, I worked in an ICU, and I think we were both surprised by the amount of documentation required by nurses, and are both in agreement that it definitely, I feel, detracts from patient care. I'll speak for a couple of minutes, or for a minute or so here. My personal experience is like I am pretty computer savvy. I do feel like I learn technology pretty quickly, and by the end of my clinical experience in the ICU, I was becoming, I want to say, like 80% proficient with the medical record in terms of what the amount I had to document and how to document that. And I was still struggling just to do basic patient care interventions, just to complete an assessment, because of the nature of the ICU. There's just so much documentation and so much patient care involved that sometimes you can't do the documentation that they require of you, just from a you must care for this patient standpoint. And there needs to be a balance between what the expectations are of the nurse in terms of documentation and what they're going to chastise you for, or try to reprimand you for not documenting when you actually are providing patient care. So yeah, it is, an EHR is definitely I feel, necessary evil might not be the term to use, but death by documentation definitely is a term I will use. And I got into nursing to care for patients, and I do recognize that documenting what you do is a part of that, but there's got to be a better balance than the way it is weighted right now, in my opinion. So,
and one of the biggest things I recognized really quickly, especially in the emergency room, was so much of their documentation in EHR was CYA. So many things that they were inputting in there was just to protect yourself from future litigation, it seemed like. And it's a bummer. It seems like that it's gotten to be that point, it's that everybody is so afraid of, being sued, which is why we document everything the way we do. It's just a bummer that it's become that way. And it's such a focus that I do believe, like you said, I think it detracts from patient care, because we're so, trying to protect ourselves from that litigation and whatnot. And yeah, I think that's definitely a huge negative for it, for sure.
for sure. Well, cool. I think yeah, I think that about sums it up. Nice job. You made some excellent points. I mean, found some stuff I would never have thought of. So
yeah, it's crazy.
Mhm.
That big hack was massive.
Yeah, that made national news. I do remember that. So, but I just, so much shit happens. I forget what happens.
I know.
Yeah.
Well,
All
cool.
right. Well,
That
take
does
it easy.
that.
Yep.